I'm the first year PEDS ID fellow, and I'm excited to share this case with you guys today. Right, all of the CME information, and I have no disclosures. All right, so the title of this case is a misdirection. So this is a case of a 12-year-old male with sickle cell trait who came in with 5 days of fever. He had bifrontal headache and non-bloody non-bilious emesis and diarrhea. He was in his usual state of health, and he first developed tactile fevers and chills. He had the bifrontal headache, which he described as squeezing in nature. He had those symptoms for a few days. They then also progressed to having crampy abdominal pain, watery diarrhea about 3 episodes per day, and emesis as well. He presented to a local urgent care 2 days prior to the presentation to us, where his workup demonstrated a white count of about 10, his hemoglobin was 12, platelets at 254, and you can see his differential and his chemistries there as well. He had negative flu and COVID testing, and then he had a UA that had about 10 whites per high-powered field, negative nitrites, some bacteria. That was on a clean catch sample. They gave him Zofran, they discharged him home, they gave him Bactrim, suspecting that he had a UTI. He had no vision disturbance, no syncope, no dizziness, no chest pain or shortness of breath or palpitations. Did not have any significant URI symptoms or cough, and otherwise was having no other significant complaints other than as mentioned in the primary history. He did have a maculopapular rash on one of the days prior to presentation in that 5-day window. And then at the time that he had initially arrived, his mom stated that she noticed that his eyes seemed somewhat erythematous when he had first arrived to the ED. In terms of things going on for him in life at the time, he had been attending a camp in the local area. He had multiple COVID exposures 1 month prior from other children who were at the camp. He did not have symptoms at that time, but he also had not tested himself either by a PCR or a home antigen test. He had no known prior COVID infections to that and was not immunized against COVID. No other known sick contacts for him, and no other significant ID exposures for him in terms of unusual foods or recent travel or animal exposures. In terms of his past history, fairly brief. He was diagnosed with sickle cell trait on his newborn screening, and otherwise has been a previously healthy 12-year-old. Family history was also non-contributory. I mentioned his COVID vaccine status. He was otherwise up to date on his routine childhood immunizations, was not taking any medications at home other than that Bactrim that he had been prescribed a few days prior. So in terms of his studies on presentation to the emergency room at Hopkins, he had a white count of 12.4, his hemoglobin was 10.4, his platelets were 279. You can see his differential, he had 81% neutrophils, 7.6 lymphs, about 5% monocytes, 5% eos, and 0.2 basophils. He had a lower sodium at 132, his K was 3.5, chloride was 90, bicarb 25, BUN was 16, creatinine was 1.4. In terms of notable other labs for him, he did have an elevated CRP to 2.0, and then his ESR was very elevated at 74, and his ferritin was elevated at 490. Interestingly, he had an elevated troponin to 3.2, and he also had an elevated pro-BNP to 1200. Exam-wise, at the time that we had seen him on our initial consult, overall he was well appearing. He did seem somewhat tired, but he was sitting up in bed. He was able to talk with us. He did not have any conjunctival injection or any jaundice at the time that we saw him. No rhinorrhea, no nasal congestion. His oropharynx was clear. Normal cardiac exam, and normal respiratory exam as well. He had maybe some like mild diffuse discomfort, but overall had nothing focal on his abdominal exam, was soft and benign. He had normal bowel sounds and no hepatosplenomegaly. His MSK exam was unrevealing. He had no joint tenderness and no swelling. And he had no rashes at the time that we saw him and no adenopathy. So in terms of his ED course, he had come in just due to progression of his symptoms over those 5 days. In the ED, initially he was hypotensive to the 70s over 30s. He had tachycardia to the 120s. He did receive a significant amount of fluid and responded well to that in terms of his pressures and his heart rate. He did have, as I had mentioned, the elevated troponin. He had this very high inflammatory markers, and he had the elevated pro-BNP to 1200. Was noted to have AKI with his creatinine to 1.4 and BUN to 16. They did an echo in the ED at bedside, which showed normal function. And then he, in the ED, was started on IVIG and methylpred for concern for MISC. So this is a 12-year-old with sickle cell trait, presented with acute febrile gastrointestinal illness, found to have fluid-responsive hypotension with laboratory evidence of significant systemic inflammation, also including elevated troponin with a normal cardiac function on echo.
Okay, wonderful. And let's see here. We have one of our excellent pediatric ID attendees. Pranita, are you aware of this case?
Hey, Paul. I don't think so. Evan, do you think I know this case?
I don't believe that you do.
Okay.
So there you are.
So I'm sorry, just to recap. So this is a child, a 12-year-old, sickle cell trait, not sickle cell disease, correct? Who's had 5 days of fever. And it sounded like on your last slide, probably the most prominent findings were some sort of gastrointestinal disease.
Yeah, his prominent symptoms coming in was a GI type illness. He had watery diarrhea, as well as several episodes of emesis a day, and that was the primary thing that he was telling us about.
Okay, and how long did this emesis go on for 5 days, or?
I believe it was the 2 or 3 days prior to presentation. He had fever first for a day or two, as the family told us.
Fever then, okay, so this is primarily GI. And then some of the things you mentioned, like the rash, the conjunctivitis, it sounds like that was very fleeting.
Very fleeting, yes.
Is that right? Okay.
Yeah,
Okay.
His mom had a photo of a rash that looked potentially like a maculopapular type rash, but was there for really like less than the course of a day.
Okay.
And then it was saying the conjunctivitis that the mom had reported was also over, the course of less than a day.
And the GI symptoms, were they mostly emesis or diarrhea or both?
It was both diarrhea first and then emesis as well.
Okay. So I think when you had started off and you were saying fever, headaches, non-bilious emesis, I was kind of leaning towards a more CNS process. Was his neurologic exam normal?
It was, yes.
It was. So nothing focal, no visual issues, no confusion.
Yeah, and as we talked with him more, like the more he was able to clarify, the more he really described like a squeezing type headache,
Okay.
more so in the setting of having his fevers.
Okay, very good. And then I guess instead of just big general processes, it sounds like infectious gastroenteritis type differential, which I'll list some organisms. You did say, emesis with diarrhea and hypotension, so it made me wonder if he could have toxic shock. And then the question would really be, where is the focus of the primary sort of staph or strep infection, if that was the case? With the hypotension, initially I was considering something like a pericarditis. Did he have anything notable in terms of a pericardial friction rub, or any sort of abnormalities on an EKG? Are you able to tell me that?
We got an EKG. It just showed sinus tachycardia. No findings to point towards pericarditis or a myocarditis. He had an echo which showed normal function and also did not reveal any effusion. I did not hear a rub on my exam.
Very good, thank you. And then he's as a 12-year-old, he's on the older side for something like a Kawasaki disease, with some of the elevated inflammatory markers and some of the symptoms. There's a few things that fit, but it certainly doesn't sound like a classic case. So I put that in parentheses. And then I feel like your title was something like not MISC, so I'm guessing it's not MISC. But if this was December of last year or something, that would have been on the differential. And then just to kind of put it on the processes, just so I don't forget to say it. If this is, obviously this is a more acute presentation, but inflammatory bowel disease, is this the first presentation of Crohn's disease, or even something like a lupus with multiple organs involved and a lot of inflammation happening? But I think, you know, I would sort of look through more common pathogens for a possible gastroenteritis first. So for this child, I would definitely get a blood culture, simply because he's been febrile for a few days, and then some stool studies. And I guess some of the organisms, I'm so sorry, last couple of questions. Any pets?
No,
Animal
no
exposures?
pets.
Any travel outside the country?
No.
And any sort of odd well water or foods he's ingested recently that's unusual, or?
So nothing that he was willing to tell us. We had kind of an interesting conversation with him when we asked him about foods, because he talked with us about how he had been spending time at this camp, and he like sheepishly looked at his mom and said, "I don't want to tell you about all the junk food I've been eating in front of her."
Okay.
But it sounds like he had you know, he was eating meals with large groups at this camp, but that was about the most interesting thing that we could find about his diet history.
Thanks. And was anyone else sick at the camp or at home?
So it was 1 month prior. There were a bunch of children there who also had COVID 1 month ago. He did not have symptoms at that time.
Okay. And I know I can't ask you too specifically, but was this sort of a warmer weather or colder weather time?
It was a warmer weather time.
Warmer weather. Okay, very good. Okay, sorry, I realized I haven't like listed any organisms. So in terms of common organisms we think of with gastroenteritis, particularly with fevers, Salmonella, Campylobacter, Shigella would go on that list, E. coli, O157H7. I think Yersinia is much less common, especially without some chitlings or some kind of unusual exposure, but it's for completeness, I guess I'll put it up there and it'll be part of the stool panel anyway. And then there's other organisms like Aeromonas, Plesiomonas. B series is something I always forget to say, but I guess because we're always taught about rice in medical school, but certainly that can present with either emesis alone or a GI illness, and it can persist for a couple of days and be pretty impressive. Without any clear, at some point I was wondering about shellfish Vibrio, but it doesn't sound like that's sort of a concern based on his lack of exposures, I guess I should say. And then I'll put C. difficile, you know, certainly we link it with antibiotics, but it's in the community and it can happen even in the absence of clear antibiotic exposure or healthcare exposures. I guess I'll put Listeria in parentheses, but I don't think of it as causing a very dramatic GI illness, particularly in an immunocompetent host. So, and we could also on that list put the Vibrio in parentheses because that seems unlikely here too. I can't think of a good fungal infection that he should have. For viruses, I don't often think of it with fevers like this, but maybe norovirus, adenovirus. I'm not concerned about things like CMV if he's otherwise immunocompetent. If this isn't sort of winter, although I guess with COVID, everything's a little unusual, but influenza seems like less of a concern. Yeah. I was at some point in your presentation, I was worried about a viral myocarditis, but I think based on what you told me with the EKG, that seems unlikely, less likely. So I'm not going to start listing other viruses that could do that. Okay. And then I guess in terms of some parasitic illnesses, Giardia, we could put up there. I think in terms of amoebiasis or even the sort of Cryptosporidium, Mysospora, Cyclospora, they all seem unlikely if he's otherwise healthy. I also don't think of them as causing high fevers like this. Or so I think those, I'm not as excited about any of those. Okay, anyway, sorry, I think I'll stop there. and see if others have other thoughts. Thank you.
Yeah, great. Thanks so much, Pranita. Nice list with lots of potentials. Anyone want to, in the audience, can speak, or Natasha can monitor the chat. Howard?
So since he was in camp, I'm going to just add rat bite fever and leptospirosis to that list. And I think probably like Pranita, I was wondering about enterovirus because that can cause some myocarditis. But he's got a normal EKG and he's got a normal echo. So probably put that in parentheses.
Enterovirus?
Enterovirus. But it's kind of classic for giving you GI symptoms and cardiac disease. So I think you have to put that on the list.
Yeah.
And then only because we don't know where this is going. If a week from now he's got the same symptoms and maybe his ferritin is a little bit higher, I'm going to just put HLH on there. I certainly wouldn't jump to that at this point, but I never really know what's going to be presented and what's kind of sitting waiting.
Yeah. Were you able to say the general geography for this camp? Was it the Mid-Atlantic, New England?
It was Mid-Atlantic.
Mid-Atlantic.
Yeah, and he didn't, it was not like a significant amount of time out in the woods and doing a lot of crazy outdoor activities. It was in the Mid-Atlantic and doing, a lot, just kind of things out in the community.
Okay, all right. Well, but he wasn't urban. He was in sort of suburban or rural areas, or was it more camp like in the city?
I think they did a little bit of both, sometimes in the suburbs and sometimes in the city.
I mean, in terms of incubation, given that this was a whole month, Babesia might come to mind. That's slower. Could potentially have a slower incubation period as opposed to rickettsial diseases or like the anaplasma, which I think are outside possibilities, but seems a little late.
He never had a sore throat.
No.
Okay, is the answer up here?
It is.
Okay, great. We're going to vote in a hurry. How is our poll master doing assembling the poll?
Good, I'll launch in just 1 second.
Okay. All righty. So he's launching, but I'm just going to go down the list and poll the audience. So please vote just once, hopefully. Who likes salmonella? Campylobacter, E. coli, Yersinia, Aeromonas, Plesiomonas, Bacillus cereus, C. diff, Listeria, Vibrio, Leptospirosis, Streptobacillus moniliformis, aka rat bite fever, which we have to list at least once a month. Norovirus, adenovirus, influenza, enterovirus, Giardia, Babesia, toxic shock, pericarditis, Kawasaki, MISC, inflammatory bowel disease, lupus, HLH. Well, we didn't get vast numbers of votes here, but I think enterovirus received the most, followed by adenovirus with some salmonella. See, once Michael tells us the polling results.
Yeah, votes are coming in. I'm sorry, I didn't make clear that Zoom limits you to 10 answer choices per question. So that's why we split it up over 4 separate questions with 1 process and 3 pathogen. But we have a good number of votes here, so I will end and share the results. So infection was felt to be the most likely process with about 3/4 of votes, with a few others getting consideration. In terms of the first grouping of pathogens, Salmonella led the way over Campylobacter, but a few others also getting 1 vote. And then in the second grouping of pathogens, adenovirus led the way over, over Listeria, norovirus, and Cryptosporidium. And then finally, enterovirus led the way with 2/3 of the vote in the third grouping. So many possibilities here, Evan. Very interesting. Look forward to your discussion.
Take the screen back. Good. All right, so I know we are about at the time mark, so I'll try to be efficient going through the rest of his case. Thankfully, we got an answer quite soon. So the remainder of his infectious work up here was negative in terms of all of the viral studies that we were able to send for him. Again, mainly focusing on GI viruses and viruses known to cause myocarditis. And then his blood culture, after about 12 hours of admission, came back positive with growth of gram-positive bacilli that then speciated to Bacillus cereus. So this was just, it was an interesting case in terms of having a pathogen that we somewhat expected, but not necessarily in the location that we were expecting to find it. So as mentioned, he got kind of initially on admission, was billed as a MISC admission, had the IVIG and steroids. They had given him a dose of ceftriaxone in the ED, and as well as doxy. I believe both of those after all of the orders had went in for all the MISC things. They got the blood cultures for him. After we had the when we had that initial gram stain from the lab, we had started on vancomycin and then we're able to transition to linezolid when we had speciation. Ultimately, he had like a soft call, maybe allergic reaction to the linezolid with a pretty mild rash, but we ended up switching him to levo to finish his course. He improved very rapidly after getting on appropriate antibiotics. So just to talk briefly about Bacillus cereus, I'll kind of go quickly through this part since it's a familiar organism to many, ubiquitous in soil and food. Obviously, the suspicion here for this case was with him eating food at camp, potentially food that may have been sitting out for a longer period of time that was being eaten in a larger group setting. That is kind of how we started to piece things together. Responsible for up to 12% of food or waterborne GI illness outbreaks, can present in kind of two distinct fashions: primary emetic disease, which is when you have preformed toxin in the food, and then diarrheal disease when you have the actual bacteria or spores in the food that's ingested. Found a number of case series just trying to look at the fact of whether there are any specific host risk factors for him in terms of the development of Bacillus cereus bacteremia. Of these case studies, kind of the themes that emerged, the biggest risk factors being indwelling central lines and IV drug use, anything that's able to introduce the bacteria more directly, just as it is so common in the environment. Obviously, immunocompromised patients at higher risk, skin breakdown, burn injuries, and then did find some, very few, but some case studies of patients with profound GI disease who there was believed to be translocation from the gut, which is kind of how we have been putting this case together for him. And then trying to think about whether there are any specific pathogen factors, virulence factors that may have contributed to this. Again, the literature here was very limited from what I could find, but there is a suggestion from some more basic science studies that these serious sphingomyelinases may contribute to potential increased virulence and an increased ability to invade, both through evading phagocytosis as well as just increasing ability to directly disrupt membranes and get into the bloodstream from the GI tract. And then lastly, I just wanted to make to highlight what we have been seeing on the pediatric side in terms of rates of MISC. And the short summary here is that cases have been decreasing dramatically. So the blue line here is a daily MISC case average. And as you can see over the course of the summer of 2022, really since the emergence of the Omicron variant, we have seen MISC almost entirely go away to quite low rates. And here's that just shown in a different form, but you can see kind of the overall incidence ratio from Omicron compared to Delta and Alpha is significantly lower.
Yeah, Evan, thanks so much for wrapping that up quickly. I mean, he was in camp a month ago, and usually B. cereus is a preformed toxin, so it tends to strike rather quickly. So this would suggest maybe some other mechanism. The case is
It had been, he had still been in camp up to, I may have not made that, the timeline as
okay.
clear.
I see.
He'd been in camp for like the duration of that previous month, up to when he presented.
But when people actually have the serious infection, it's not related to trauma or surgery or something. Usually people are sick or immune compromised. Is there any hint that he might have underlying health problems? I mean, I'm not usually thinking sickle trait is one of those, just
Correct, yeah,
because
we,
it's unusual to have bacteria.
Yeah, and
it's causing serious illness.
yeah, and it really gave us pause in terms of knowing that B series could be a common contaminant and knowing that we really don't have a good answer to that
Mhm.
question.
Yeah.
Gave us some pause. But we did have kind of a consistent initial syndrome for him in terms of his GI illness, and he got better on therapy. Yeah, it's still a curiosity.
Yeah, I mean, because
exactly what
usually
set
it's
him up for this.
self-limited, right?
Yeah,
You know,
absolutely.
the diarrheal component gets better on its own.
Was it one culture that it grew from, and were there other cultures that were?
We only had one culture prior to antibiotics. So it was only one that grew.
The other thing that I thought could fit is, B series is a toxin producing organism. It's not classically associated with myocarditis, but he did have a very strong flavor of a toxic shock-like syndrome with pretty profound initial hypotension, these various kind of rash conjunctivitis description initially that was already gone when we saw him. And that just kind of more pronounced troponin elevation to up to 25, I think was the peak. So I don't know if he happened to get a virulent strain or some toxin that was a little bit more dramatic than your typical organism.
Great. Well, thanks.